to everyone to this new webinar of International Academy of Cytology. It is a great pleasure today to have here Professor Lukas Bubendorf from the University of Basel. Well, Professor Bubendorf is well known to everyone. He's a histopathologist and cytopathologist, and he is the head of cytopathology at the Institute of Pathology at the University of Basel. He is well known for research on genomics and genomic alteration in solid tumors, both in histology and cytology, and also because of the application of molecular tests in cytology. And today we'll speak about the second edition of the Paris system for reporting urinary cytology, and it is a great pleasure, Lukas, to have you with us. This session is recorded and can be seen after on the EASC YouTube channel. So thank you, Lukas, very much, and the floor is to you.
Thank you very much, Massimo, for the introduction and also for providing the opportunity to talk for this very international audience. And I'm also glad that many of you are here at not very convenient hours, depending on from where you are. For some, it's very early, and for some, it might be very late. For me, it's just quite normal in the morning. So it's, yeah. So the talk will be about the second edition of the Paris system. And in many institutions, the urinary cytology makes quite a large proportion of everything which is going into cytology. Urinary cytology is not so old, but it's also not young at all. It's 77 years ago, actually, when it has been described as a useful tool to potentially detect neoplastic cells in urines. And no surprise, this was by George Papanikolaou, who published this evidence or this paper in a very prestigious journal, as you see. Since then, a lot has happened. The indications for urinary cytology as we do it is usually hematuria in voided urine. So if a person has hematuria, cytology of voided urine is the first thing that is usually being done. Then any suspicious lesion at cystoscopy, that's usually red patches that are either inflammatory or carcinoma in situ, should be evaluated by cytology. And the largest proportion actually of cytology specimens that are seen in a, let's say, academic environment are the surveillance urinary cytologies in patients who had earlier resected urothelial carcinoma, knowing that these tumors recur in usually 70% of all cases. And another intriguing indication is control after therapy with intravesical BCG to see whether it was successful or not. We have known for a long time that detection of CIS and non-visible high-grade cancer is the main purpose and the main strength of cytology, of urinary cytology. Now, looking at the types of urinary cytology that we encounter, the proportions vary depending on where you work and which environment. It's voided urine. In our environment, it's mostly bladder washing. Then catheter urine is less common. Upper urinary tract cytology, brushes or washings, but also forced diuresis after giving diuretica is also a typical indication. And there are others, less common ones, which I won't get into. Before we go to the actual aspects of the Paris system, I will spend a few words about technical factors, which are also mentioned in the Paris book, but which are recognizably important. So usually it's thought that one or two cytospin specimens are representative for a bladder in a washing and voided urine. Most institutions use two washings or two preparations, and Papanikolaou staining is the standard. It is also highly recommended to use pre-treated slides, so not the cheapest glasses that you find, but glasses that have been covered with polylysine, which improves adherence, which is important if you want to do ancillary testing, be it immunocytochemistry or FISH or whatever. because it just improves the adherence. The cells won't flow off. Now, cytospins are not the only modality that can be used. Some laboratories, I'll show you some statistic afterwards, prefer thin prep, the liquid-based preparation that we also know from Diagnostic Cytology, or another type of liquid preparation, the SurePath. These are equivalent all to each other. It always depends on how you have been educated and what's your daily practice, and you get used to your daily practice. Well, this is a survey that global survey that has been done a few years ago to see what urinary preparation types are being used. And as you can see on the right, like you see the colors, like cytospins is used by a bit more of 1/3 of all laboratories. Liquid-based preparation, thin prep mostly, but also SurePath are together more prevalent than thin preps actually. Fewer labs use direct smear, which I find not so ideal because you spread the rare cells over a whole slide. And if you want to go for ancillary testing, it's getting difficult to collect your cells or find your cells. It's also a little bit more difficult to screen the slides if you have to screen the whole slide surface. This slide gives like the rationale, one of the rationales why the Paris system had actually been introduced. And we have done this study quite a while ago in 2006, because, you know, like you as well, like everyone noticed, there is kind of a diagnostic mess in urinary cytology and also in terms of classification systems. In this survey, we had 50 cases and we collected more than 12,000 answers from almost 250 participants, and there were some interesting results concerning the inter-observer variability, which was quite huge in some cases. But one important aspect, we also queried about the classification used globally, and there were 29 different classification systems being used. So that prevents any progress in harmonizing the field if there is so much heterogeneity. So another issue, limitation of cytology has always been the variable proportion of atypical cells being reported in those specimens, irrespective of whether these were academic or private centers. And this was also a pre-TPS Paris system survey done by Dr. Rosenthal, and she found this large variation from 1.8 to almost 25% rate of atypical, which questions the whole endeavor of urinary cytology if we are getting unspecific with vague diagnosis. So that was, these limitations were the rationale, while this in the upper left image, you see 5 people, and you might know most of them. That was the International Congress of Cytology that took place in Paris, and we came together to think about these issues and to set the stage for a new harmonized system. And a decision was made at that point, and that's probably a very important decision, changed the paradigm. We recognize that diagnosing high-grade Eurotelia carcinoma, there is a high concordance, and everyone agrees that's the main purpose of cytology, and we should build on this fact. This group had then rapidly grown to a very international group of urinary cytologists, and also a few urologists were involved, as you can see. Now, this resulted eventually in the first Paris system book in the year 2016. And the focus was, so the main purpose was really to diagnose or exclude high-grade urothelial carcinoma. So it's focusing on high-grade urothelial carcinoma, leaving away all the other troubles that we have with low-grade urothelial neoplasias. So the first book came out in 2016. From then on, there was a rapid growth in the number of papers that took it up and did studies and comparison with previous diagnosis, and there was a gain of knowledge, and this eventually made us to put together a second edition, which has which is almost double as thick as the first one, because there are a lot of new things, a lot of new data that have come up in the meantime, so it was an update. There is evidence on how the TPS1 system, as it was defined, performed in clinical practice, how the data look out. They were introduced in this book. New areas of research were defined, and most importantly, many more images were included, just to get you to get the users better accustomed to the definitions. And there is a quite large chapter on the history of urinary cytology, and that's probably the best ever written chapter on this particular topic, and it's really worth looking at. It has been written by Stefan Pambuchian. Unfortunately, he passed away while the book was going into production. One issue that always needs to be addressed, and that was a consensus now in the TPS book, was the adequacy of cytological specimens. That's across all fields, that's always an issue. It has remained a bit controversial because there is not a lot of evidence in the literature. Clearly, an area of future research to better define the definition or define the criteria for adequacy of urinary specimens. So it's always the questions volume versus cellularity. And there is an agreement that, based on some literature, that you would need at least 30 milliliters of voided urine in order to have an adequate specimen. And the cellularity, there is decently good evidence that you need 10 to 5 urinary cells per 10 HB high power fields, meaning 1 to 5 cells per HBF. That's not a lot, and this is true for the instrumented specimens. It's also important to note that whenever you see an atypical finding or a positive finding, a specimen is always adequate. Only if you see benign specimens or insufficient number of cells and the criteria of adequacy are not met, that it becomes inadequate. So I won't go into the details here. You can read that afterwards of this, how to proceed. So this summarizes the categories of the Paris system. It has actually not changed or not changed much. We have 3 very important, or let's see, 2 very important. As said, we are focusing really on high-grade urothelial carcinoma, and diagnosing high-grade is the main target. We need to focus on that, high-grade urothelial carcinoma. Then there is the quite annoying category of atypical urothelial cell. We need to keep the percentage of AUC cases as low as possible. That's the other important point. In the TPS second edition, there is a nice summary. It's called TPS in a nutshell. It summarizes all the criteria per category. And it also shows on the 2 right rows the frequency according to the literature and the risk of high-grade malignancy, so of high-grade urothelial carcinoma. That's always important to have an idea what we're saying. For example, for atypical cells, they should occur, or they occur in 5 to 15% of all specimens. And the risk of high-grade malignancy lies between 25 to a bit more than 50%. There are quite large ranges, and as we go on in the future, it will be more stringent. It will be more narrow, hopefully. There will be more definite answers to those. You also see on this table that there is no low-grade urothelial neoplasia category. I will talk a bit about this later. Now, the criteria, high-grade carcinoma, high-grade urothelial carcinoma is at the center of our interest and focus. And these are the criteria. So there must be a high NC ratio of at least 0.7. There must be hyperchromasia. The chromatin must be irregular and clumpy, and there are irregular nuclear contours. So all of these criteria should be present to make a clear diagnosis of high-grade urothelial carcinoma. So the NC ratio is an important criterion in this whole whole system, and there has actually been an analytical study done like 5 to 6 years ago, and the authors measured digitally the true NC ratio in the cells, and they made this scheme here. And if you look at that, you know, 0.7, if you take the real measured NC ratio, that's really high. You hardly see any cytoplasm. And honestly, when we look at it, when we eyeball cases, we have in the past, many of us in the past have used the 0.5, 0.6 as 0.7. So actually, we tend to overestimate the NC ratio by looking at it. So nevertheless, this was raised a lot of discussions in the group, but we didn't want to change anything. We didn't want to change the NC ratio for high-grade urothelial carcinoma to 0.5 because, you know, all evidence that has been gathered not by volumetric or digital analysis, but by eyeballing by our eyes. So we stick with our rules, acknowledging that we may overestimate the true NC ratio. Now, before we diagnose high-grade urothelial carcinoma, we must also know something about the negatives, what we should call negative, and how to avoid reactive conditions to be called atypical. And what you see here is a typical bladder washing specimens with urothelial cells, including umbrella cells. They're often multinucleated. On the right, you see small tissue fragments. That's how they are called in the book, but actually there are more aggregates of cells because they don't contain tissues. These are often overestimated as being evidence of low-grade papillary tumors, but actually they are not. They are often found in bladder washings, less commonly in voided urines, but you may see them in voided urines. It's just normal urothelial cells. They may be reactive in a way. This is also, these are two cases of typical reactive changes. On the left, you see a so-called iridative bladder, which is actually a clinical diagnosis with many multinucleated umbrella cells, but no change in NC ratio, no hyperchromasia, and so on. That's just reactive. The category is negative for high-grade urothelial carcinoma. On the right is the same. It looks a little bit unusual. We have those aggregates, these rounded aggregates as well. This was a case after BCG, but that's far away from being high-grade urothelial carcinoma. Degenerative atopia is certainly also not a field that remains under-investigated, and further efforts are needed to gain more insights into this, because we might tend to overcall them as atypical, suspicious, or even high-grade. The rule is, when you look at degenerate cells, be very cautious about making a positive diagnosis. For example, in these cases, these were diagnosed by us. The two cases on the left, we recognize they are typical, but we are not so confident about just calling them negative degenerative. We call them atypical urothelial cells. On the right, you clearly see the cytoplasm is gone or is degenerating, the nuclei decay. We have apoptotic changes, but the NC ratio is not high. You know, this is clearly just degenerate cells. It's just negative. Some problems here now with proceeding. Oh, now it's gone. That's an autoreactive case. That's from a patient who had intravesical mitomycin treatment because of a non-invasive high-grade urothelial carcinoma. Of course, those nuclei are in a way atypical. They appear even hyperchromatic, and chromatin is not very normal, but the NC ratio is completely normal. And you even see an umbrella cell up here. So these are highly reactive cells. who suffered from the effect of this cytostatic treatment. Now, these are very typical rounded aggregates that we often see in bladder washings or upper urinary tract washing. I refer to them as hedgehogs. They are a little bit like a little hedgehog who rounds itself up and makes this globular structure. And in the past, this has often been misinterpreted as low-grade papillary urothelial neoplasia. In fact, it's just a physical phenomenon. If groups of cells float in the fluid, they tend to round themselves up like a hedgehog who feels the dangers of an animal around or a human. Same thing. You can safely call those as negative without any thought. Of course, you always need to look at the cytology as well. There are rare cases of high-grade urothelial carcinoma that form similar structures, but they have the clear criteria of high-grade urothelial carcinoma. Virus-associated changes always go to the negative for high-grade urothelial carcinoma category. The most dangerous one, pitfall, are decoy cells, polyoma virus-infected cells. People are more familiar with herpes infections from other organ systems. They're all negative by high-grade, and HPV coilocytes or cells from low-grade dysplasia can also be encountered. We usually make a comment about their significance, but it always goes as negative for high-grade urothelial carcinoma. Some words about the decoy cells. They have first been described over 50 years ago by a technician in Dr. Leopold Koss's lab, Andrew Ritchie, and he recognized that these decoy cells can be mistaken for carcinoma cells. Probably he mistook them himself, and I'm sure many of you have had similar thoughts when they looked at these cells for the first time. In fact, it's just nuclei filled with viral DNA. This causes these dark nucleus, but it has a ground glass appearance like viral inclusions. But if you're not familiar with this and you find this in a voided urine for the first time, you can easily call it malignant right away, because some of the cells are really very hyperchromatic and the NC ratio is at least increased, but you see the ground glass appearance, and that calls your attention and must make you very cautious. And when you go back and see what patients these are often patients under immunosuppressions, especially patients after kidney transplantation. That was a Zika virus infection, reactivation actually. Well, the thing is that these decoy cells have many phases. That's a continuum of morphological changes. On the left, you see the classic ground glass cell with this comet-like cytoplasm. So if you see one of those, you are absolutely sure it's decoy cells. But you know, also the vesicular ones are decoy cells. These cells make a transitions while the infection evolves. At some point, they look like reticular nuclei. It looks like a spider web. It's still a decoy cell. If you would have only the hyperchromatic ones, it gets difficult. They look like carcinoma cells. But you practically always you have all the other morphologies as well, especially one or another cell with the classic morphology. Now let's go into the most important topic, the high-grade urothelial carcinoma. And we can go through the criteria, which I already listed. So the NC ratio clearly larger than 0.7. They are hyperchromatic. They have irregularities of the chromatin, and they have an irregular nuclear membrane, in that case, especially the contour, but also the thickness. We know many other features that are typical for high-grade urothelial carcinoma, such as dyscohesiveness, eccentric nucleoli, maybe some mitosis, but they do not count in the world of the Paris system. All that counts are the strong criteria mentioned above. Actually, if you look at such a case, you know, a normal experienced cytologist knows immediately that this is high-grade urothelial carcinoma. And that takes me to my 5 seconds rule. If we can make the call right away within 5 seconds, it's high-grade urothelial carcinoma. After some time, of course, you don't go through these criteria, you internalize them into your mind and you look at it and you can just do it quickly. Now, if you look at this case, everyone would agree, yes, that's also high-grade urothelial carcinoma. And you also see the histology, it was PDA high-grade urothelial carcinoma. They have large variation in size and shape, very high nuclear cytoplasmic ratio, some membrane irregularity, maybe some chromatin abnormalities, but they are not hyperchromatic. Well, if you go through the specimen, you will always find one or another cell that you might call hyperchromatic. And actually the chromacy of high-grade urothelial carcinoma is very diverse across the specimen in many cases, but overall that's just hypochromatic, and still we call such a case as high-grade urothelial carcinoma. That's a new aspect that has been introduced in the TPS system. And in the last few years, actually 3 papers came out who described this phenomenon, like high-grade urothelial carcinoma with hypochromatic nuclei, and you see some examples. They have all the criteria, but they lack the hypochromasia. And in all of those 3 studies, the prevalence of such hypochromatic cells at high-grade urothelial carcinoma was around 15%, so it's not so rare. That's another case from our own practice on the left. Very high nuclear cytoplasmic ratio, not at all hyperchromatic, but when you look at the histology, it's really what you see in cytology. In histology, you see some more hypochromatic cells, but you also see few hypochromatic cells in cytology, like here. If you search for them, you find them. It's an interesting phenomenon. It will be interesting to see what sits behind this phenomenon. Is there a molecular change or another change that would explain this strange morphology? That's also area of future research. Now, if we are not completely sure, if we believe that the case is high-grade urothelial carcinoma, but we are not completely sure, then we call it suspicious of high-grade urothelial carcinoma. So for this diagnosis, we need an NC ratio again of at least 0.7. And not all of the three other criteria are fulfilled. So if we have only hypochromasia and irregular chromatin, but normal nuclear membranes, so it's just not everything met, then we might be more comfortable by calling it suspicious. Well, many cases of high-grade urothelial carcinoma or diagnoses are made in cases where all the criteria are met, but where are only few cells. And this is between 5 and 10 vital malignant cells. So if we have only, that's one case that you see, we would call this high-grade urothelial carcinoma, but we have only 5 cells. No one will blame you if you just call that suspicious and don't make a definitive diagnosis. It's the safer way to do it. It has the same consequences. They won't send the patient home. You know, it's the same consequences. Oh, yeah. Yeah, that's a case of bladder washing after intravesical BCG in a patient with previously confirmed carcinoma in situ. And you can see here that you have several cells who meet the criteria of high-grade urothelial carcinoma. The NC ratio is not very high in each of those cells, but overall you call these, but it's quite a low number of cells. Now you have the choice. I would call that high-grade urothelial carcinoma, but it's not totally wrong to call it suspicious of high-grade if you have less than 10 of these cells. Here we are around 10. It depends a little bit on your temperament probably and on your daily mood. Well, low-grade urothelial neoplasia, I listed it here as it was listed in the TPS1 system. It's not a category anymore in the TPS2 because it has been incorporated in the negative, that's wrong here, negative for high-grade urothelial carcinoma. Because a low-grade urothelial neoplasia is negative for high grade. Everyone will agree about that. Nevertheless, we can make the diagnosis. If we see a case that we are sure it's low-grade urothelial neoplasia, then we say it in the text diagnosis. We say we have cells of a low-grade urothelial neoplasia, but the category, TBS category, will be negative for high grade. It's just to emphasize even more the importance of negative for high grade and high grade urothelial carcinoma, and not spend too much time on dissecting the diagnosis of low grade urothelial neoplasia. So to make the call or the descriptive diagnosis of low grade urothelial carcinoma, you need true papillae, which are cellular three-dimensional clusters with a fibrovascular core. If you don't have a fibrovascular core, you can do it. You can suspect low-grade urothelial neoplasia if you have other features like clusters, cellular clusters, monotonous single cells with uniform cytoplasm and mild irregularities of membrane and increased NC ratio. You can always suspect it. But anyway, it's always negative for high grade. So that's a typical example. You look at it in the cytology, you see a papillary structure, it's highly cellular, you see the monotony of the cells, they even have increased NC ratio, but they have not a single feature of high-grade urothelial carcinoma. This is a low-grade urothelial neoplasia, and it goes into negative for high-grade urothelial carcinoma category. And that was the histology. That was really a very low-grade papillary urothelial carcinoma. You even see some sort of prevailing umbrella cells, which can happen in low-grade urothelial neoplasia. Well, if you are well experienced, you will be able to recognize that such a case is also low-grade urothelial neoplasia. But according to the rules, you shouldn't call it, you should just suspect and say that's suspicious of low-grade urothelial neoplasia, but it goes into the category of negative for high-grade urothelial carcinoma. Now, what do you see? You see the monotony. All cells look the same. There is increased NC ratio, and there is thickened nuclear membranes, mildly thickened nuclear membrane, but it's certainly not hyperchromatic, and it's certainly not high-grade. Now, the more a little bit annoying category, which is the atypical urothelial cells. Here we need one major criterion that must be fulfilled, which is an increased NC ratio. And in that case, we don't need the 0.7, but 0.5. So we are more liberal in calling it AUC. But you need, that's not enough. You need something else. You need at least one, or not at least, you need only one of the other three criteria, like mild nuclear hyperchromasia, not very strong. Of course, then it would be suspicious of high grade. Some irregularities of the chromatin and some irregularities in nuclear membranes. So before making this diagnosis, we need to exclude all benign reactive changes. If it looks like reactive changes, no need to call it atypical, please. And if we make it a call of atypical AUC, there must be a certain probability that these cells are in fact from high-grade urothelial carcinoma. When we believe that it could be low-grade, some low-grade features, but we are sure it's not high-grade, then don't call it AUC, just call it negative for high-grade. Well, it's difficult to find very good educational cases of AUC because everyone has his own thresholds in a way. That's a case that we call the atypical urothelial cells. I show you two more of those on the left, and on the right you will agree probably they look very similar to each other. On the left you see some umbrella cells adjacent to those mildly atypical cells. You see in both groups you see the increased NC ratio, you see at least irregularities of the nuclear membrane, and that justifies already the AUC diagnosis. The one on the left proved to be negative in follow-up and histology, and the one on the right proved to be from high-grade urothelial carcinoma. Now, there have been several studies since the TPS1 book, and it showed, fortunately, that applying the TPS rules, you can reduce the atypicals. That was our goal, actually, and this is achieved. So on the left, you see our own data from like 3,900 cases from the post-TPS era, so diagnosed in daily practice. And the prevalence of AUC was 0.6%, so it was less than 5, which is quite satisfactory, I find. And there have been other studies comparing results from the pre-TPS to the post-TPS prevalence. In the upper study showed there was at least a reduction from almost 19 to 14, which is not yet ideal. I would say 14 is still enough. And in the other study below, they reduced it from a very high 29% to a low 6.5%. So in the meantime, there have been additional studies that have come out. So it shows that we can clearly reduce it to a rate of around 5%. That's what you want to achieve, and that's what you should also try to achieve, to make it meaningful, to make AUC a meaning diagnosis. And this is illustrated in this recent showing that, in fact, that TPS makes the diagnosis meaningful, because it was the diagnostic category was compared with the histological diagnosis of high-grade urothelial carcinoma. And in the post-TPS area, around 50% of the AUC cases proved to be high-grade urothelial carcinoma. And in the pre-TPS area, it was around between 5 and 10%. That's meaningless. It has become meaningful, while high-grade urothelial carcinoma, negative for high-grade, has always been meaningful. Now, the TPS system also sets the stage to define categories where diagnostic marker analysis make most sense. And that's clearly the categories. These are the equivocal categories, the atypical urothelial cells. If you want to know in an individual case whether it's now malignant or not, we can choose diagnostic markers. This is not so useful in negative for high grade, and it's not at all useful in the high grade. In individual cases of suspicious of high grade, the clinicians want more certainty, and then you might still send the specimen for molecular or diagnostic testing. So again, to emphasize, in case of high-grade urothelial carcinoma, no markers needed. In negative for high-grade urothelial carcinoma, in my opinion, it makes no sense to apply a marker because if we don't see atypical cells, we won't see carcinoma cells by applying a test. It makes sense in the atypical urothelial cells. Now, when you look at, there is an increasing number of diagnostic markers that have been proposed for urinary specimens, but there is a biomarker problem in the literature because many studies use large basket diagnosis of bladder cancer as an endpoint. And it's very fuzzy because they put just low-grade urothelial neoplasia and high-grade together without distinction. And this makes no sense because we know high-grade is the important tumor and not low-grade. And in addition, in many studies, they just ignore the cytological finding. It's not even mentioned. So if you have a poor cytology performance, then you automatically improve the biomarker performance, but this has nothing to do with daily practice. And there is a big market with many commercial interests in the field that you keep in your mind. There are some markers out there that have even been FDA approved. Some of them, the upper half not marked, are done by the urologist themselves. They just send the urine, a test result comes out, and we never see those. So it does not concern us. They also suffer from some issues. They have a low specificity. So those tests are not frequently used, or not at all, at least in our environment here. And there are two FDA-approved assays to be applied on the cytological specimens. That's the UCyte. It's an immunofluorescent test. I won't expand on this one because it has gone out of the market. I was not so convinced about it anyway. And there is the Eurovision FISH test, fluorescent cytohybridization, which is still out there and approved and is being used variably across different countries. Now, there is a lot of movement in there, a lot of dynamics in molecular markers in urinary cytology, and that shows the reasons for that. You know, like bladder cancer usually has a lot of mutations, and this is true across all classifications from non-invasive to invasive and muscle invasive. And like third telomerase mutations are found in up to 80% of all bladder cancers. And also FGFR3 mutations and other mutations are quite prevalent. So if you mix those together, you can anticipate that you get a fairly sensitive and probably also specific test. And that was actually the starting point for many new markers or assays that have come out, especially next generation sequencing assays where you can look at a whole number of mutations, and they have quite promising results with high sensitivity, but also high specificity. So I would say it's really promising, but it's not at all a standard of practice. Just stay tuned. There will be more results coming and will be interesting to see what happens. But many of these studies are problematic in a way I just explained. They're just, the endpoint is fuzzy. It's not clear whether they really help to detect the high grade or whether they're just a marker for low grade and so on. So more work is to be done, but it's very promising because theoretically those mutations should be specific for neoplasia. Well, they will have an increasing role in the future. That's the current state, current recommendation of the two large associations, AUA and EAU. And they recognize the potential benefit of some markers, especially in the field of response monitoring to intravesical BCG, where Eurovision FISH is especially mentioned, and in case of equivocal cytology, referring to the AUC categories. And in the EAU, they also recognize that different tests may have promise in order to identify patients at higher risk, but none of the markers are actually recommended for routine practice or to replace any current standard of diagnostic procedures for the time being, at least. Now, for the time being, it's this fluorescent cytohybridization, Eurovision FISH, the one that can be used and where a lot of literature is around. I don't want to make experts out of you of FISH, because some of you might also already have some experience, at least theoretical. It's not so difficult. So we are looking at 3 different chromosomal probes for chromosome 3, 7, and 17, labeled in different colors, and 1 locus-specific probe, which is 9p21. And in a normal cells, of course, you have 2 signals each for each of the signals. And if you have a deviations of this normal pattern, it's abnormal. And there are rules or thresholds when to call a case positive. If you have at least 4 cells having multiple copies of 3, 7, or 17, or a loss of 9p21, which is a very typical feature in bladder cancer, then you can call it positive. Also, there is some more granularity into it, whether you also consider heterozygous loss or homozygous loss of 9p21. It's not a webinar about FISH, so I won't go into more details. Just one thing again. In many reactive conditions, you may find tetraploid cells. So a cell under stress physiologically doubles the whole genome to be more effective. And that doubles all the chromosomes. So if you have, in a normal cells, 2 copies for each chromosome, you have 4 copies for each chromosome in a tetraploid cells. It doesn't mean that it's a tumor cells, because it can also occur in reactive cells. And that's a potential pitfall in this assay. If you call tetraploid cells as positive, then you may create false positive cases. Another important aspect of fish testing in urinary cytology is that you want to look at specific cells or cell groups of interest and not just take a specimens and go randomly over it and look for cells. So it's really much more rewarding having automated relocation with a automated stage, and first relocate your cells, identify, save the coordinates of the cells, remove the cover slip to the fish, and go back to the very cells. And then you really know what you want to know. And you limit the possibility of looking at the wrong cells. So this facilitates review and the sign-out time, of course. We can look at rare atypical cells of interest. It increases diagnostic precision, and it has a teaching process because you know exactly that your atypical cells that you were concerned about are either fish positive or negative, and you can memorize it for future applications theoretically. Yeah, this is one of those examples showing that it's very crucial really to combine molecular analysis with cytomorphology. You cannot let anyone do the fish analysis who has no idea about morphology. Now look at these very peculiar cells. For someone with no idea about cytology, it looks scary, you know, huge nuclei with nucleoli and so. But as cytologists, we knew that these are just reactive umbrella cells. And if you do a fish analysis on those, it looks like this. They have these cells are under stress because of the urine and the reactive conditions in the bladder. They do an endoreplication, they duplicate or triplicate the genome, and you see these clouds of signals. But this is not positive. A person having no idea about cytology will call those cells positive, but we call them negative. It's just a polyploid or tetraploid reactive cells. It looks scary, but it's quite harmless. This shows our experience of fish analysis in these conditions in our own lab. So when we have AUC, almost 50% of all cases were fish positive, indicating that were in fact neoplastic and high-grade urothelial carcinoma, while around 40% were negative. Like in many tests, you also have equivocal results, and these were 13%. That this case had either a tetraploid pattern or the result was at the very threshold with only very few positive cells. No surprise, if you have a diagnosis of suspicious of high grade, the vast majority will have a positive test result. Well, this illustrates practical examples. We are looking at 3 upper urinary tract washing specimens, and all patients were evaluated for the possibility of urothelial neoplasia. Now, you can make your own decision how you would call them. Of course, there is always pre-diagnostic probability condition. If a patient had previous urothelial carcinoma and he's under control, there is by definition a higher risk of neoplasia. We don't talk about these clinical aspects here. And it's not of relevance. The one on the left, we called it negative for high-grade urothelial carcinoma because that's how upper urinary tract specimens look like. You see the NC ratio, you see umbrella cells, and so on. And in the middle, at that time, we called it AUC. Maybe today I would call it reactive negative for high-grade urothelial carcinoma. But it's clear you see some cells with increased NC ratio, you see membrane irregularities. It turned out to be a reactive condition because of a lithiasis. It was fish negative. And the one on the left, it looks not on the right, it looks not so dissimilar to the one on the very left. But the nuclei may be a little bit, well, the NC ratio is higher, and there are irregularities of the nuclear membrane, yes. So we called it atypical urothelial cells. And fish showed that the 3 chromosomes were normal, but the 9p21 locus in gold had lost 1 copy in all of the cells. So it was a clonal proliferation, it was neoplastic, it was heterozygous, but it was clearly neoplastic. And it turned out to be a muscle-invasive pelvic urothelial carcinoma. Upper urinary tract cytology can be quite tricky, you know. you must be very careful not to miss things, but also not to overcall things. And we find it very useful to apply FISH in these conditions. That's another case. Some of you might also call as atypical urothelial neoplasia, as atypical urothelial cells, as we did. Maybe today, after more experience, I might call it negative. Well, we did FISH analysis. The first diagnosis was atypical urothelial cells. Then we did FISH, it was negative. Then we called it negative for high-grade urothelial carcinoma. So you can revert your category if you have new evidence on molecular testing or FISH testing, and have a final category after ancillary testing. That's another recent example. This patient has a history of high-grade urothelial carcinoma of the bladder. So there is a pre-test increased probability of being positive. But when you look at the cells, and that was the ureter washing, several years after that, after the bladder cancer, the patient had BCG, and now there was some new evidence. I don't know whether they saw something or whether it was just a regular control. Anyway, you look at those cells and the NC ratio is increased. You have irregular chromatin. The membrane is a little bit thickened, but the NC ratio admittedly is clearly below 0.7. Nevertheless, we call it suspicious of high-grade urothelial carcinoma. You might also call it atypical urothelial cell in this case. We did FISH, and now you see a tetraploid pattern in the 3 chromosomes shown in blue, green, and red. But you see, if you look very closely at the microscope, then you see each of the cells has not 4 gold 9p21 signals, but 5. So we are really dealing with a clonal proliferation. That's not explainable by any reactive change. That's not a pure reactive tetraploidy. That's a clonal proliferation. So we can tell that it's certainly high grade. It's certainly neoplastic. We may stick with the diagnosis of suspicious of high grade. It's neoplastic. It's probably high grade, but it might also be low grade. So we don't have to be firm on this one, but we can clarify it's neoplastic. That leads me already to the take-home message. A TPS1 and TPS2 improved the standardization and defined categories for ancillary testing. So by having clear categories, we can determine which tumor would be suitable for ancillary testing. And I've shown you that the TPS system 1 has clearly improved the performance of urinary cytology, especially by increasing the value of AUC. Eurovision FISH is a helpful tool in difficult cases, as shown for AUC and suspicious of high-grade urothelial carcinoma. And there are really interesting new developments in ancillary marker testing. Stay tuned, especially in terms of genomic panels. And I could really advise you to take a look at the TPS2 system. It's out since quite a while now. You can get it. It's also, I think it should also be available as an online version. So thank you very much. And I just want to acknowledge the whole Paris team who has continuously been working in a really joint effort to move this project forward, and also our own team who have easily adopted the system, including the urologist. Thank you very much.
Thank you very much, Lukas, for this overview and especially for the practical cases that you showed us. Before to check for question, I have 2 questions for you. The first one is for immunohistochemistry. Do you change your technical approach to urine if you know that you have to perform immunohistochemistry? For example, if you know that there is a prostatic cancer, I mean, you do directly a cell block, you do a cytospin, you do a film prep, and you perform immuno on film prep. What is your approach?
Well, that depends really on the lab where you work. So we do all the immunocytochemistry on Papa Nicolau stain specimens. So in case of the bladder, we use just the Papa Nicolau preparation that we have. We uncover it and stain it with our protocols, and it works. Some other labs use thin prep in the first place. That works as well. I'm not so fond of the cell blocks. Well, first of all, most bladder specimens are not so highly cellular that you get nice cell blocks, and I would never do it in the first place a cell block instead of a Papa Nicolau. You can always do one in case you have a lot of remaining sediment. That's fine, but you know, we never actually are in need of it. If you do if you plan to do immunocytochemistry more frequently, it's again important to use adhesive slides. Otherwise, you may lose your cells that you want to look at.
Thank you. And the other question is related to this one. There is also a test using cytokeratin 17 that seems to be useful for detecting bladder carcinoma. What do you think? Do you have any experience?
Well, all the immunocytochemistry tools that I have seen so far have not held their promise. But I'm not absolutely. What was it called? CK7? 17.
17.
No, I have no
keratin 17.
No, I have not. Well,
just one of the other.
It would be so nice to have a magic bullet, just a immunocytochemical marker, but I wouldn't be optimistic here.
Okay, so Lukas, if you want to go through the question in the discussion.
Yes, there is the first question. That's a very good one. How long can a treatment effect after BCG be seen in urine cytology? Well, that really. Well, the answer is I don't know, and the second part of the answer is it really depends on how you define a treatment effect. You know, that's a continuous change. There is not yes and no, and but from my guess, I would say it's probably several months. It's not for years. It's not like radiation treatment where you see the effects for years. That's not the case for BCG. Could you please share your immunohistochemistry protocol? Well, it depends on what you, immunohistochemistry, well, there are different protocols. So I haven't talked about immunocytochemistry. We do not do it frequently in bladder cancer, certainly not for diagnostic purposes. You might do it in cases where you are not sure whether you are really dealing with urothelial carcinoma or an extravesical tumor. In most cases, that would be prostate cancer that has invaded the bladder wall. And that's quite a common application. If you are not sure about that, we use NKX3.1, a very reliable prostate marker. And we use maybe GATA3, which is not so specific, and CK7, because practically all prostate cancers are CK7 negative, while practically all bladder cancers, urothelial carcinoma, CK7 positives. So it's the same protocols that we use in lung and other specimens. It's not specific protocols for bladder. We do some, well, there is some interesting opportunities in the predictive field, potentially predictive field, like surrogate markers of mutations. Like ARID-A1 is a marker that has been associated with poor response to intravesical BCG, and we have established a protocol for ARID-A1. And if we have high-grade urothelial carcinoma and fitting clinical setting, we do that. And if there is a loss of ARID-A1, this is in favor of an ARID-A1 mutation. So the next question refers to FISH, the tetraploid pattern. You know, the tetraploid pattern is it's a tricky thing. In our studies, we set the threshold at larger than 3. So if we have less than 10 cells with the tetraploid pattern, then we call it negative, and we say it's consistent with the reactive changes, but also always having the respective morphology in mind. You know, you cannot do it irrespective of the cytology. If that would fit with cytology, is fine. But if you have clearly more than 10 cells, we better keep it AUC or whatsoever and ambiguous, and say that in fact urothelial carcinoma with a pure tetraploid pattern, they exist. It's not so that every tetraploidy is reactive. Tetraploid urothelial carcinomas do exist. Yeah, that's the answer to that. Whenever you have a 9p21 deletion, it's set, you know, then you are dealing with the neoplasia.
Thank you very much, Lucas. There are no more questions, and thank you for having been with us. And thank you to all the participants. You are more than 100 to listen to Lukas Bubendorf. And I would like to invite you to another webinar at the end of October about artificial intelligence in cytology that will be led by a resident in cytology from South Africa, Dr. Loon. So please check on the International Academy of Cytology website for news and for next webinar. Thank you very much, and thank you again, Lucas.
Yeah, thank you. Bye. Have a good day.
Bye-bye.